Bismillahirrahmanirrahim. Assalamu alaikum. A 76-year-old man with multi-infarct dementia came to the emergency department due to cough and low-grade fever. He was treated for pneumonia twice in the last year. For the past 6 months, he has had difficulty swallowing and has occasionally regurgitated undigested food. The patient has a lengthy history of hypertension and chronic atrial fibrillation. BMI is 22 kg, temperature 38.5, blood pressure is 150 by 95, and pulse is 102 per minute. Respiration are 16 per minute. Physical examination is notable for foul smelling breath and a fluctuant mass in the left neck. Auscultation show crickles in the right lung base. Chest X-ray shown an infiltrate without cavitation in the right lower lung field. The patient is admitted to the hospital. Sputum and blood culture are sent to the laboratory and antibiotics are started. A few days later, the patient condition is markedly improved. Which of the following is the most appropriate next step in management of this patient? So this is a 76-year-old man. He came to the emergency department due to cough and low-grade fever. The patient first history include that he having pneumonia having pneumonia twice in the last year. For for the past 6 months, he has had difficulty swallowing and has occasionally regurgitated undigested food. On physical examination, we show that there is a foul-smelling breath and a fluctuant mass in the left neck. Auscultation show crickles in the right lung base. Chest X-ray shown an infiltrate without cavitation in the right lower lung field. Based on these, here the diagnosis of this question is Zenker diverticulum. Zenker diverticulum, and due to Zenker diverticulum, this patient having again and again the aspiration pneumonia. And the management for the Zenker diverticulum is contrast esophagography. I will contrast esophagography. So recurrent pneumonia is an elderly patient with dysphagia and regurgitation of undigested food, rising strong suspicion for a Zenker diverticulum, a pouch posterior to the esophagus that formed due to herniation of the esophageal mucosa through an area of muscle weakness, which can lead to insidious onset of progressive dysphagia. Trapping of food in the pouch can lead to halitosis, which is foul-smelling breath. Patient often regurgitate the undigested food or medication several hours after eating, which can lead to aspiration and recurrent aspiration pneumonia. Pouch occasionally becomes so large that it is palpable, as in this patient, which swallow food with contrast esophagography confirm the diagnosis. I will show the photo of the Zenker diverticulum. So this is the Zenker diverticulum, which show that there is a false diverticulum. We show the esophageal obstruction, which can lead to dysphagia. And here on the gray, I will highlight it here. This is the retained food, which will result into halitosis, which is a foul-smelling discharge. And this is impaired crocopharyngeal relaxation. Here is the food regurgitation, and here the food regurgitation will lead to the pulmonary aspiration, which is called which can lead to recurrent pneumonia. Come to the incorrect one, choice A, bronchoscopy. So bronchoscopy, patient having an obstructing mass, then we will go to only bronchoscopy. Choice C, gastric feeding tube placement. So gastric feeding tube placement will be an immature because surgical treatment for Zenker diverticulum is enough. Choice D, neck mass biopsy. So this patient has clear-cut the sign and symptom of diagnosis of Zenker diverticulum. So neck mass biopsy is not needed in this patient. Choice E, upper gastrointestinal endoscopy. So upper gastrointestinal endoscopy is not as sensitive as esophagography for detecting Zenker diverticulum because the opening of small diverticula may not be visible. Endoscopy can be confusing or even risky if the cannula inadvertently enter the diverticulum during the procedure.